Good afternoon, everybody, and welcome to our Southeast Respiratory Support webinar on the COVID virtual ward, oximetry at home and discharge on oxygen. My name is Julia Bott and I'm one of the clinical co-leads with Joe Congleton for the Kent Surrey Sussex Academic Health Science Network. So just before we start, there's been a slide up while you've been coming in, and just note the housekeeping, please, that by taking part you give implicit consent to be recorded, and keep your video and your microphone on mute, your video off, in any case for the better working of the webinar, but particularly if you don't wish to be seen or heard. If you want to interrupt or ask a question, you can use the raise hand function, but there are an awful lot of us on this call and time is very tight. So please do use the chat box for your questions, and we will try and read and pick up as many as possible for our speakers to answer. So I'm now going to hand over to Joe.
Thank you, Julia, and a welcome to all our speakers and attendees. So the pandemic has led to a need for rapid changes in the way we practice, and rapid adoption of new pathways was the primary aim of keeping a bed base to enable safe patient care. And so this afternoon we're going to highlight and explain 3 pathways which are concerned with monitoring oxygenation of SARS-2 coronavirus infected patients in a home environment. And we'll hear about the implementation and how those systems work in real life. So to start the session, I'm delighted to introduce Richard Russell to give an introductory overview. So Richard is here as Respiratory Clinical Lead for the Southeast region, but he's also a respiratory consultant in Lymington, where he's a clinical director for the Community Integrated Respiratory Service. And if that wasn't enough, he also has academic sessions in Oxford. I'm sure there's much more. So over to you. Thank you.
Thank you, Joe. Thank you, Julia, and thank you for sharing and being very kind in doing this. And it's absolutely fantastic that we've been able to launch this and do this so quickly and easily. Can you all see my slides okay?
Yeah, we can.
Yes, we can.
Lovely. Perfect. So this is me, and if anyone needs anything from me, please do email me either at Imperial College or Oxford or through Southern Health, which is where I am. So I'd like to be contacted, so please do feel free to do this. What I'm going to do nice and quickly is run through the underpinnings of this, the need, the underpinning of the service, what the potentials could be, and the various models. Now, I know people are all doing various things, and there's all sorts of work being done all over the country. And as usual, I'm going to push to see we need to find solutions which fit in with the services which we have and the geography that we actually have on our patients' needs, which is really important. I'm then going to finish by giving a couple of top tips for change, and also from my national role, so a few answers to a few questions that we've actually had, and this is very much work in progress across the whole patch. Why do we need this? Well, because this is the current state of patients with COVID patients in the United Kingdom at this time, with approximately nearly half of the hospital beds within the whole of the country full of COVID patients. And there's huge pressure on the system there. And so can we do things differently to actually manage patients in a safe but different way? And this has been driven by Matt Inada Kim, who's one of our local people, it's important to say. Matt's a acute physician at Winchester, and he is also the lead for out of hospital care, and actually had a think about how we deliver and how we can monitor COVID patients. And it's been published extensively about doing home care for patients with COVID disease, whether we can do admission avoidance and early discharge. And I got interested in this as a community COPD doctor because we obviously do this with COPD, and it's not that dissimilar. Okay, and there was evidence early on that many of the patients who are being transported to hospital because of the unknown nature of COVID actually had relatively normal oxygen saturations. Now, they can change, and that's the whole point of what Matt then designed. So Matt, with some other colleagues in the South Central Ambulance Service and others, did a validation of the use of home oxygen as a marker of clinical deterioration, and showed quite clearly that actually looking at a baseline oxygen saturation and monitoring this can predict very strongly the need for admission to hospital and the mortality rate. And that's been validated in various other studies when you've looked at cohorts retrospectively who've been hospitalized with COVID-19, that the oximetry itself is a very helpful predictor of the need for admission to hospital and requirement for admission to hospital, more than actually pulse, more than actually respiratory rate on its own. And this is not, but it's not just quite that simple. Oxygen measurement is really critical in how we do it, and I'm pulling together here some of the materials that you can see, some of the materials given to patients, and again, very clearly showing that actually that if you do get this right, that actually you can make a difference. The other thing that Matt took on, which is also really important, was clearly the identification that people were coming to hospital with COVID too late and therefore dying. So if you turn up in hospital 2 days later, you're in a much worse state and needing much more respiratory care and much more CPAP, much more intensive care intervention, and therefore your prognosis is also worse. So clearly it's about getting these people who don't need to be in hospital, keeping them away from hospital, but also identifying absolutely at the right moment when they do need to be admitted to hospital. So it's a very tightly linked thing, and it needs to be managed very carefully and very closely. So there's the whole pathway is about monitoring and then recognition with appropriate escalation into intervention as needed. This is not about bullying on and pushing on to keep someone who's unwell out of hospital. I'll be very clear about that. So work that was done very early, particularly over in Manchester, showed very clearly that actually you can save a significant number of bed days and beds admissions to hospital for people who are managed in the home rather than the community setting. Readmission rates are generally low, and across the southeast, this is reported on Monday to our medical directors, was actually readmission rates are about 4% in the southeast if you're on a COVID oximetry at home or a COVID virtual ward. So we need to watch this, and a significant number do end up back in hospital, but a significant number of people are kept out of hospital. Data again I got on Monday from Southampton Hospital shows that they send home from A&E 10 people a day with positive COVID tests. These people need to be monitored, and that's why this seminar has been arranged for today. So what can be achieved from the potentials of a COVID virtual ward and COVID oximetry at home? Well, we can stop people going into hospital or attending hospital, keeping the units clear for people who need to be there, monitoring them properly. We can do potentially admission avoidance for those who are safely sent back home. We believe that patient experience, and there is some data on this, has been improved because we also will be removing barriers. And one of the things I want to say is that COVID virtual wards and COVID oximetry services need to have as a safety net, as a psychological safety, but also as a real safety. These patients are in a place of being monitored and need to be able to access hospitals promptly, rapidly, without having to go through all the barriers that we normally put in place, which is really important. Patients empowered to manage their own health, which is a good thing, and we are able to escalate quickly. I also want to suggest to you that the COVID virtual wards and the COVID oximetry at homes are a fantastic way of primary and secondary care coming together to work closely together. And with the fact that the integrated care services are going to be made statutory and mandatory at some time in the next year or so, this is going to happen more. These barriers that we have already about silo care are going to be broken down. I want to try and break through the silos that we have. These are pathways. These are not silos of care. I've just been on a meeting nationally with the national leads about this, and it was made very clear. We need to understand this is not, we're not talking about oximetry services. We're talking about clinical assessment services. And I think people need to understand that it's a mistake to think this is just about monitoring people's saturations. It's not. You do not switch off your brain. You do not switch off your medical and nursing and your clinical skills because someone's got an oximeter on their finger. So what are we doing in this region at the moment? Well, COVID oximetry has been rolled out. It's about keeping people with COVID safe at home. Over 9,000 patient contacts in the southeast so far. Still more sites to go active, generally being run by primary care with safety netting. And I think there's an opportunity to build on that now. We can build on that with the COVID virtual ward. It's a little bit more patchy and more model variability across the patch. And this is about, and these are my quotes, preventing unnecessary COVID admissions. More than 200 patients have been enrolled so far, and there's some very good examples of delivery in Oxford, the Royal Surrey, Reading, and Milton Keynes. So it is being done now, and there are models out there already delivering care. What are the key points? Well, for me, this does not need to be respiratory led. In fact, I think it is better not respiratory led. In Oxford, it is led by the ambulatory care team. The respiratory team did not know anything about this service. It's better if it's led by people who know how to manage risk and how to manage people and make decisions about admission. Respiratory physicians are not those people. So it may well be primary care, ED, acute medicine, ambulatory care. As I've already mentioned, there is a huge issue for safety netting. I insist on this with my COPD patients, my asthma patients, and direct admission to appropriate places in hospital without going through ED is really, really important. Staffing is helped by having an HP lead, also by using colleagues who are shielding, because this doesn't take away from any clinical service then. And as I said, readmission rates we can be reassured about are significantly below 10%. So we can carry this risk, or people can carry this risk. And then there's another model, which I'll talk about in a second, which may be extendable to COVID early discharge. This is less evidence supported. It's more concerning. It will definitely involve respiratory teams in this, but it's not limited by oxygen supply at this time. But many of you out there manage oxygen, and my team manage oxygen, and we all know oxygen is really easy to start, but very hard to stop and take away. And I'm one of the big things the meeting I've just come out of is I've asked people to share their oxygen withdrawal, oxygen wean pathways with us. So in general, there's two things, and I see these potentially blending. One is COVID oximetry at home, which is generally primary care supervised with lower complexity perhaps than acuity, with community diagnosed, and it's an admission avoidance service, versus the virtual ward, which is maybe hospital supervised, but again, I think these could blend, and we'll hear more about that later on this afternoon. Slightly higher acuity and complexity, people coming out of ED or ambulatory care or admission units, which is generally then supported as an early supportive discharge. Big debate about dexamethasone at home. Initiated at home, no. Maybe continued at home from people being discharged from hospital, perhaps. But if someone needs dexamethasone, they probably need admission to hospital. This is a couple of just really simple flags. You can see how simple it is. This is how to run a 24/7 minimum requirements model for an oximetry at home service. You can monitor people's oxygens, and you have very clear pathways. That's the only reason this is up for, very clear pathways for what you do if things change, and everyone knows about that. Matin Kim's worked very hard on this and has developed, this is, for example, the ambulance pathway that was only approved this morning. So this is actually a decision support tool for adults with confirmed COVID within the ambulance to fit into a COVID at home service. So there's a lot being done. And this is one from the early supportive discharge guidance as well, which again, I'm very happy to share. This is from NHS London as well, if we're going to get people out of hospital earlier. So a few top tips for change. What has been successful so far? Clearly, there needs to be clear leadership, clinical leadership, but also project management, because there's a complexity to what we're doing and administration. You need to have to beginning frequent, effective meetings. From little huddles of groups making things forward to move forward to an overall review run by the project manager with clear timelines and objectives. This is change management. Very clear referral criteria and the pathways. People have also recommended if you need oximeters, order them as soon as possible, because that's a potential delay. And I'm suggesting, as I've said already, use your local knowledge and expertise, your geography, your existing teams. And then finally, two things. You need to develop a pull culture. What do I mean by that? I mean, if you have a service, you go looking for patients and you pull them into your service rather than having people pushed on you. It is much more efficient, much more proactive, and reduces delay, as well as involving people, engaging people with your services. Pulling people into services is so much more efficient. And don't reinvent the wheel, because it exists already. So these were my FAQs when I wrote this little talk about how we do a few things. So staffing, you can be creative with the staffing. Use what you've got, but maybe use people who are shielding, or people at home. Primary care, secondary care, I don't think it matters. And again, they can be blended. Who should be involved? Well, certainly I would try and keep respiratory physicians, speaking as one, unless you have a significant clinical role, out of it, because we don't understand necessarily in hospital how to do this. And Joe may have views on that. Are there apps to use? Yes, there are. There are some apps being developed and trialed at the moment that may really help manage the actual problems that we have. What are the pitfalls? I think the pitfalls are risk and managing the risk. Not many patients will need admission, and the follow-up, we need to work out through our pathways how we do it with clear exit strategies for the pathways as well, because this is really tricky. And finally, where to go for help? Well, help is available. Nationally, locally, there's enormous resource, and the AHSN has a huge amount of resource available for you to actually use. And I, myself and the AHSN team will be very happy to move you on with this. And finally, my last slide is just a picture taken from what is already available. It is already being done. You do not need to reinvent the wheel. There's material out there. This is a patient information sheet, which has already been published and approved and can be used by you all. So thank you for that. It's a real quick overview of the models. 3 models: home oximetry, COVID virtual wards, and potentially early discharge planning as well. But that's yet to be seen. Thank you.
Thank you, Richard. That was an excellent overview, and you got through it well. Thanks a lot. Are you able to stick around, because there might be some questions later?
I'm here all afternoon with you guys. I want to learn, so yeah, please.
Okay, so we are going to hear about Oxygen to Wean at Home programme in our third session. But first of all, let's start with the Oximetry at Home programme, which, if you think about it, is the start of the pathway. So we're going to hear both from Ursula Clark, who's Patient Safety Lead for the Kent Surrey Sussex Patient Safety Collaborative within the AHSN, and then followed by Caroline O'Keefe, who's a GP and Clinical Director. And that reminded me, and you mentioned the AHSN just then, Richard, that this webinar is a collaboration between Wessex, Oxford and Kent Surrey Sussex AHSN. So hopefully with these sessions we'll have some time for questions. So if you do have questions, just pop them into the chat box, and even if we don't have time, we'll answer them later. So over to you, Ursula. Thank you.
I'll just share my screen. Thank you. Hi everybody. You will have heard quite a bit from Richard already. So I just wanted to kind of start off by saying that we have been involved in this probably since last October. So Kent, Surrey, Sussex, Oxford and Wessex got together to work out how we could actually, on a request from our regional medical director, actually from Vaughan Lewis, just to see how we could support all the ICSs to actually implement oximetry at home. So we decided, and Caroline is going to follow on and actually give an example from a GP perspective, but we decided that we would look at what our offer would be, and we have been involved very much with doing insight, and I'm going to show you, that's the one thing I'm going to show you, is just a couple of heat maps of what we've been doing. We've actually, Richard talked about the guidance, and we've been very influential in actually supporting people to do toolkits and to actually find out where all this information is, which is all there for people to use. We've supported with policies. We've actually done quite a bit of signposting. We've links with NHSE, NHSX, also links with some comprehensive training, for example, restore training within a care home environment. We've actually taken the opportunity to continue in areas like that. And we've done, like we're doing today, we've supported networking and soundboarding and engagement meetings where people actually, we can learn from each other, can't we? So it's all about actually doing that. So just very quickly before we go to Karen, I was just going to show how the analytics team, what we've done is they've actually looked at assumptive. So what we would presume if we were to take all of the 30% vulnerable at-risk groups and base that on a modelling against with the known number of cases in any given week. This is what we send out on a weekly basis. And though it's not the actual numbers, it does give us an idea about whether infections are going up or down. So every week we send through, within Kent, Surrey and Sussex, we actually do send through potential referrals which may happen, which has supported ICSs to look at the number of oximeters that they actually need. We then drill that down even more and we look at particular areas, particular PCNs and where they actually may be, making sure that they've got enough availability resource to support this. We've done comparative data and we can see there are some reductions in the numbers, but we do also know that the numbers of admissions within our hospitals are actually remaining pretty much high. The other area, just to say, and I know Joe's going to talk later on, Joe Murray's going to talk later on about webinars. So we've been very much involved in sharing and looking at different types of webinars and learning opportunities that there are available. And I just wanted to finally, this is my final slide, I just wanted to say that we have been, there've been quite a bit of discussions really regionally, nationally, locally about the terminology that's been used. I think when Oximetry at Home came out first, people were calling it virtual ward, but in fact it needs to be called Oximetry at Home. And I put this kind of together because to me this is quite simple. So it's actually dependent on where primary care. So primary care actually look after the oximetry at home. They invariably look after the admission avoidance within the ED pathways, and that rarely look after ambulatory care. Secondary care, they actually look after the virtual wards. So these are patients who have been admitted and the early support to discharge. There is also in some areas a variance where actually existing acute respiratory physicians continue to refer to the community respiratory physicians and actually maintain that, although that may be increased with patients who are COVID positive. And then something that's been propping up in the last week or so, maybe and nationally they'll be looking at, is a maternity model. So that to me is actually how we should be looking at it. Although I do agree there are quite a few variations in place across KSS in particular, and I'm sure within Oxford and Wessex as well. So I'll hand over now to Caroline to continue. Thanks, Carlos.
Thank you very much, Ursula. That's really helpful. Can you see my slides?
Yep.
Yeah, fantastic. Thank you. So I was just asked to give an example of our journey, I suppose, over the last 9 to 12 months, just to give you an idea of what's been happening in North Hampshire and to give an example of a COVID oximetry at home service that's been set up. So just for a bit of background, I work in North Hampshire. We cover 6 primary care networks with our sort of joined up COVID response, which covers a population of about 230,000. In the first wave, we set up a hot hub or a COVID assessment service, and I did a lot of work with Matt and Ada Kim, who Richard's already mentioned, who was on our patch, and we probably started talking March or April time last year, particularly about the silent hypoxia phenomenon, which was very much noticed during COVID. So during the first wave, we ran a hot site and started to sort of, I suppose, just pilot handing out some pulse oximeters to start looking at a sort of very early model of this service. So where we are in wave 2 is we have set up another hot site, a winter assessment hub covering the same population, and really seeing everybody locally in the North Hampshire region with a viral illness. And that's started, you'd expect, from the practices. But co-located from that, we decided to set up a COVID oximetry at home pathway. So this opened in North Hampshire on the 2nd of November. So we've been running just over 12 weeks now. It's a 7-day-a-week service. We use our urgent care provider, our out of hours provider, NHUC, who I believe covers some of the Kent, Surrey, Sussex region as well. So they're able to provide that service 7 days a week. The way we are staffing our COVID oximetry at home pathway, we have 2 fantastic lead ANPs who share the role across those 7 days. And initially on setup, it was being run by 2 individuals, the lead ANP supported by a care coordinator from one of our PCNs. And very similar to other models across the country, we set up some pretty simple pulse oximetry packs containing the oximeter itself, a series of instructions, paper diary, linked to a fantastic YouTube video that was designed by a colleague of mine in Winchester, and then a self-addressed envelope for returns. So we wanted to keep this as simple as we could. Now that hasn't evolved hugely since we started, although we're probably a bit slicker with the instructions that we put in. But otherwise, the aim really is to keep this model as simple and as replicatable as possible. Again, we have a very simple referral pathway. We have a direct line and we have a dedicated email address. We just wanted to make the service as accessible as possible, both to primary care, but also to colleagues in emergency departments, in SCAS, really anyone who needs to refer into the service. We started with again a fairly simple IT solution where we have an EMIS platform and those 6 primary care networks share EMIS, which made it very straightforward. So we used the EMIS platform and used Accurix text and the COVID monitoring Florey to communicate with patients. We have recently and within the last couple of weeks switched onto the in-healthcare platform. We've done that. That's a commissioned service across the whole of Hampshire and the Isle of Wight. I have to say, I think we're pretty glad we did, given our recent surge in numbers. The EMIS and Accurix solution is perfectly doable and was a great way to get us started. But as you'll see, our numbers have increased dramatically recently. So I think something that is a little more slick, I suppose, from an IT point of view has helped us. But I do want to make the point here that you don't have to have a slick IT solution in order to get a COVID oximetry at home service set up and running. I think this can be done with an Excel spreadsheet and paper and pen if necessary. I think the most important thing about these services is getting them going and communicating and talking to people about them. And then at its very basic level, it is a monitoring service, and exactly as Richard said, an assessment service overseen by our lead A&P, who identifies any deterioration, checks the data and then acts on it. Clearly, although we have an IT solution, we also can work with paper diaries and telephone numbers for those people who don't have access to that. So our current situation, as I said, we've been going 12 weeks. We've onboarded 485 patients into the service. We currently have 174 active in the service, and that's covering that population of 230,000. A few of those are in care homes. We have, over the last couple of weeks, had some quite nasty care home outbreaks, but actually we're seeing more of the tail end of those now. So we've got a bigger population at their own homes. We've discharged 311 from the back end of the service. And that early detection or readmission rate that Richard was talking about currently sits for us at 42. And sadly, we've had 16 deaths of people on the pathway, although predominantly those were people from care homes who were possibly reaching the end of life anyway. So just to give you an idea, this was our sort of patients who were seen at our hot hub. And certainly locally, we're hoping that we're just over the back of a peak within the hot hub. But interestingly, our COVID oximetry at home service continues to climb. And I think that there are probably a few reasons for that. I think practices and primary care are getting better at active case finding. And I suspect that's why we are, again, sort of echoing what Richard said, we are pulling people very much into the service. Rather than waiting to be pushed. So I just wanted to highlight in the last couple of minutes some of the lessons that we've learned from what we have set up and the journey we've been on over the last 12 weeks. Just to give you an idea, the picture on the right of this slide gives an idea of what the in-healthcare platform looks like. There are plenty of platforms out there, but as you can see, obviously I've cut off anything patient identifiable, but 3 times a day we get a series of metrics submitted by patients that can be visualized in quite a straightforward way, and we can then identify which are the ones we need to pick up the phone or contact or make sure they've made their way to hospital or contact them for another monitoring or bring them into a hot hub. So I think it's certainly helping now that we've got nearly 180 people on our platform. I think we learnt a lot of lessons from those care home outbreaks, particularly, and it's been a plea I've made multiple times locally here, particularly making sure that all of primary care have respect forms in place in care homes and that we can identify who is suitable for escalation and who's better to be managed in the home. Once that's been identified, we've set up twice weekly MDTs where we really put anyone in who has an interest in any of our patients on the pathway. So we bring in representatives from each of the primary care networks, we bring in palliative care teams, we bring in the hospice at home teams. This is where we bring our respiratory consultants in, we bring in our ambulatory care consultants from secondary care. And I would only echo what Richard said about this being a fantastic opportunity for collaboration and strengthening links with people across the system, really. I think we're working in such a different way to where we were a year ago. And this is only a positive, and we have to hang on to this in one way or another. So I think once those patients are identified, particularly in care homes, we can still put a lot of wraparound support around those people who maybe are going to continue to be managed in the home. We've sort of looking, and you'll notice from the slide on the number of patients we've got in the service, we clearly had to increase our capacity when we moved from managing 30 or 40 patients to managing nearly 200. And we've used the additional role scheme staff from each of the individual PCNs to help support that. So I still have a lead ANP who is fantastic and absolutely pivotal, but I now have a team of 5 working on the COVID oximetry at home pathway every day of the week. And the additional 4 staff are made up of care coordinators, health and wellbeing coaches, social prescribers, really people who are brilliant at this and brilliant at putting support around patients, but with the clinical oversight. And that's been really valuable, pulling people in, and lovely to see the multidisciplinary team working so well together. I talked about active case finding, and I think that's something that, although we've been running 12 weeks, we have only got really a lot better at over the last few weeks. And that is essentially reviewing all of those positive cases. So I do that for my PCN. Every single positive case comes past me, and I identify who's high risk and goes to the COVID oximetry at home pathway, and who's low risk, and we can manage with some simple safety netting. And that's part of that pull model of making sure we've got the right people on the pathway. There's certainly discussion, and I don't know, I suspect Rich and I were on the same meeting this morning, but a discussion about lowering our definition of those high risk patients from 65 down to 50, and that's based on the data and what's being seen in the second wave as we speak. And then finally, I know we're moving straight on to talk about this now, so I just wanted to finish on the interface between our primary care COVID oximetry at home and then the secondary care virtual wards. Certainly locally for us, they are being headed up by our ambulatory care team, and I think the links and the strength in communication between those 2 services is hugely valuable. There needs to be a very clear delineation as to which patients go into which service, but also those 2 services need to be talking. And actually, at the moment, the local setup with us is that we will be talking daily to identify who's on which of those services and how we can move patients between them as they hopefully improve. So I'll stop talking there, just from a time point of view, and hand back over. But again, happy to take questions.
Thank you, Ursula, and thank you, Caroline. That's great. So we've got some great questions in the chat. Some have been answered, but we'll move on to the next session now. And I think maybe, Caroline, you can answer some, and we might have a little bit of time at the end, but thanks both. So if we think about the pathway, the next step is people who've largely actually ended up in ED or the acute medical ward, and this is what I think these are the patients that can go potentially into the COVID virtual ward. So we're going to hear from Jo Murray, who's Patient Safety Programme Manager for Oxford AHSN, and Jo's going to tell us about their experience. So over to you.
Great. Can you see my slides?
Yeah, we can. Thank you.
Fantastic. Thank you. So so just sharing a couple of the models that we've got within our footprint within Oxford AHSN. So the Royal Berkshire Hospital, their model is called TIC-19, which is Triage into Community COVID-19 Pathway. And taking us back now 10 months in our journey through COVID, they set up their service back in March 2020. And really, if we think back to where we were at that time, we didn't know much in this country, and they picked up a lot of their learning from Italy, and in particular, where, if you remember back then, that's where the outbreak had occurred, literally the month or 2 before us, and we saw what might be coming. And they picked up this idea of using point of care ultrasound testing as part of the diagnosis for COVID-19, and they use this both within their hot hub, so they rapidly set up training sessions and with GPs to be able to use it for diagnosis of COVID, so to prevent patients having to come in for x-rays, as well as using it within the ED department. And their model is to use physician's assistants through their acute medical unit, and they provide a 7-day service, and they have an integrated service where they monitor both the hot hub patients and the hospital patient through the same monitoring team. So truly integrated, and they use data at the time to plan where they should put their services. So even from the point of where should they place their hot hub, so the centre of Reading was the correct place to put it. And then they added on an additional enhanced respiratory service that's GP-led to cover the more rural patch of Berkshire West locality. They also have GPs offering pulse oximetry for patients to self-monitor, and that's the GP-led service. So again, lots of bits of service that all come together, but the main one that we're focusing on for this session is the TIC-19, the hospital service. And as they've been doing this for quite a while now, they've made improvements along the way, so including pregnant patients and any specific requirements around that particular group, and that's been in the chat as well about what's happening with that, so that's being looked at nationally now. VT thromboprophylaxis was added in as we learned a little bit more about the disease process and an additional pathway for picking up patients if they're picked up later on in their disease, as we recognise not all patients are coming in on kind of day one and testing from kind of day one of disease process, that they might be picked up further down the line, and some adjustments to the pathway. A little bit of data from TIC-19. So in wave 1, they saw a total of about 300 patients, so from March to the summer period, where they actually stood down their service as we had a lull, and then they restarted again in October, and they have seen 600 patients and counting. So these are just the patients that are either stepped down ED or patients that have been sent through to the hot hub for assessment. So this data doesn't include any patients that are seen by the enhanced respiratory service or those that are having pulse oximeters through the GP service. So then moving on to Oxford University Hospitals model that Richard mentioned earlier as well. So they set up in November 2020 as part of our rollout across the region, and took a lot of the learning from other sites around the country that had started this. They again use, as has been mentioned, it's their acute ambulatory hospital, acute hospital at home service, their AHA service, and they have experienced nurses that undertake the calls, sometimes 2 calls a day, precise assessments of risk, and then they have dedicated consultant overview of that, and that is, as Richard mentioned, it's the ambulatory care service that's covering that. So they have a weekly multidisciplinary team, as you can see there, and as Caroline mentioned, this ends up being a multidisciplinary piece of work in terms of managing patients, answering their queries, keeping them safe and out of hospital. They have dedicated pharmacy support so that they can rapidly make adjustments and changes to that. They support their COVID dialysis unit. They've linked in with care homes, so when there's been outbreaks, they've then moved into, again, keeping patients out of hospital, providing treatment where appropriate in the care home setting for those patients. And again, their data looks very similar to the Reading model. This is starting at, say, in November, and you can see this is when Christmas happened, and then here we've got our big peak that's occurred. I've just added in a couple of other examples from around the country, just as data starting to come out now, which is just really exciting to see how services are sharing what's happened. And so Salford is another example. They again set up in October. They've seen 683 patients. They're using shielding staff as call handlers. Patients are staying in this virtual setting for an average length stay of 7 days. And again, this is all sort of contributing to supporting the flow of patients and capacity and managing patients safely in a setting that's not in the hospital. Another example is West Hertfordshire. This is the first virtual ward that was set up in the UK, and they've seen 3,700 patients and counting. This one is managed by their consultant respiratory physicians. This is Matthew Knight and co, and they have made use of an app. So again, the systems where you've got the big numbers, they're using apps to support, and that's not the only route. They do still do telephone and paper diaries for those patients that aren't digitally enabled or just need that extra support. But again, the app can help support patients, particularly those that are self-monitoring, and to help manage larger numbers of patients to spot those where you need to target your resources. So just leading on to what we're doing now, within Oxford HSN, now that we've got all of our pathways implemented across our footprint, we're now comparing pathways, looking at our data to see, okay, what can we learn from each other based on that. Buckinghamshire have also got their COVID virtual ward set up at the same time as Oxford. Milton Keynes started last week. Brimley were already accepting patients from ED, have now expanded to, let's just say, ward step down, apologies. And this is a fast moving area. Guidance is changing. I saw in the chat somebody mentioning, there's lots of drafts and information, and that's literally how this work is happening at the moment, with people sharing their drafts, their experience, little bits of data, feeding that up nationally so that we can share and help influence and adjust guidance. We're within Bob ICS, we're feeding the daily data now into the instant command meeting, so it's truly helping with kind of patient flow and capacity across the ICS. And again, we're in the process of implementing the digital platform in healthcare that has been implemented successfully in Wessex. So we're sharing the learning. As Ursula mentioned, we've been working as the 3 HSNs since October time, and we're linking in with NHSE South East colleagues. I'm also looking in with the Southwest region, weekly meetings. We have National Learning Network. We've run a number of Royal College of GP webinars over the last few months jointly with the AHSN, and just recently we've had one that will focus specifically on COVID oximetry at home. And we've got the planning for a care homes webinar coming up shortly, so that will support that sector as well. Escalating to the national team. So as I said, this is fast moving, lots of information that's coming up. Some of it a little bit anecdotal, but if you're getting several bits of anecdotal data coming from around the country, you can start to pull that together and say, we've got a bit of a theme here, let's investigate this a little bit more thoroughly. And so sharing issues, big ones at the moment around data capture, but transferring patients out of area. We had a little problem with some of our bachelor pulse oximeters, checking on that, and Ursula's already mentioned the pregnancy pathway. So my last couple of slides are just to share with you the resources, and these will all be shared, so you'll have all the links. So we developed a toolkit that we launched in September for the COVID oximetry at home pathway, and that was a small group of us from national team, including colleagues from our 3 HSNs in the southeast. And then building on the success of that, we then did very quickly, within the space of about 24 hours, put together the toolkit for the COVID virtual ward along the same line. So all of that is collated and ready for you. There's so much out there already. Please do not reinvent the wheel, I think is the key message. Patient leaflets, translated information, the video that Caroline mentioned, the animation to help patients with how to use pulse oximeters safely. There's a number of links that I'll share. The Reading crew have had a couple of articles published as well that will support, and as I say, a number of webinars that are focused specifically on the COVID virtual ward model. And then we've got some additional webinars coming up, as there's one next week for our Southeast region, and then the next National Learning Network meeting will be on the 9th of February. So there's a lot of opportunity to engage and link in with other services that are delivering around the country. Thank you.
Thank you very much, Jo, and thank you for keeping to time. So we've got time for a question or two, but can I also ask our speakers just to have a look through the chat and see if there's any afterwards, and just see if there's any questions that you can address. I know Rich has been doing a great job there, and others. So Julia, do we have a question?
Well, there are a lot. So Caroline and Jo, thank you very much. There's lots of questions. There's quite a lot of concern around the younger age group and around those from BAME backgrounds, and about the thresholds for the younger generation and for the use of oximetry and decisions made based on oximetry in those with dark skin. And I just wondered if you had some comments around those two things, please.
Yeah, I'm happy to take the question about dark skin, and perhaps also some of the information about the younger population, and perhaps other colleagues, please do jump in. There is plans, if not already started, to do a prospective study around people with different skin pigmentation. As Julia's already mentioned in the chat, The papers that are mentioned are from several years ago and were based around patients in intensive care, so very sick patients. It was small numbers, and the inaccuracies are happening at sort of 80% and lower. So in terms of patients that we'll be seeing on these services, we're looking at the 90s and the low 90s where there is a concern. And the advice at the moment has been that we never take any one reading as the only thing that we focus on. Apologies if you can hear my son in the background. That we also focus on whole symptoms and clinical assessment of each individual. So just taking extra care for our colleagues with different skin pigmentation, that you may need to be mindful of other signs and symptoms for those and look at trends.
Thank you. I think Richard mentioned that earlier. Look at the whole picture, isn't it? And never rely on one thing. Was there something you wanted to add to that, Caroline, or did that answer that?
No, I think answered it perfectly. It's all about the trends, and we always make sure when we onboard somebody to the COVID oximetry at home that we identify what their baseline is, because I think if we've got a baseline and we can look for deterioration from that baseline, then we've got a really good idea how someone's doing. Yeah,
I agree. Trends are really important. Richard, I think you've got something to come in there.
Just to add on that, and Joe, you can add as a respiratory physician, this is absolutely essential to monitor change, and just picking a number and sticking with it, although on a population basis really helpful, for an individual patient is absolutely not. And bear in mind underlying disease such as COPD, heart failure as well, which can obviously, and peripheral vascular disease, which can interfere with these things. So you've got to use your clinical skills as well as just the number.
Great. Okay, well, there's lots of resources there. Thank you very much, Joe. And we're going to move on now, and something that, Richard, you mentioned you hadn't heard much of, but in fact, the acute trusts, west and east of my own, are running oxygen to wean at home. We need to think of a snappy phrase for it. So we're going to hear now from two of my colleagues in Brighton and Hove. Sabi Hippolyte, who's a consultant respiratory physician colleague, and Marcello Rossi, who's the lead community respiratory nurse for the hospital at home service. So Sabi's going to start off about the hospital end and let you know what they've been doing.
Oh, so hopefully you can see my slides.
Yeah, yes. We can now.
Yeah,
that's fine.
Good. So I'm Sabi. I'm one of the respiratory consultants at Brighton, and Marcello is is the lead practitioner for the our hospital at home service. So we developed a planned weaning for people with SARS-CoV-2 still requiring oxygen in the first wave, and I must admit, in the first wave, I think maybe as people have alluded to earlier on in this session, there was so much uncertainty that it wasn't used in large numbers, but it was used for patients who needed significant periods of home oxygen. So it was actually in the first wave only used by 5 patients, but all of those patients needed more than 35 days of home oxygen. So it certainly had a high impact for saving bed days and just a higher quality of a patient experience. So I'll definitely also reiterate the importance of going out onto the wards and trying to find people. So in the last few weeks, that's definitely what I've been doing, and with our specialist nurses, just going onto every single ward, as obviously the majority of COVID patients are not being cared for in our trust anyway by respiratory consultants, because there's not enough of us to go around. So our criteria are that the patients have to be over 18 and with no underlying respiratory disease. Obviously, we do accept some people with underlying respiratory disease, but just to keep it simple, we're saying that. They have to be clinically improving. By that, we mean be it day 10 and beyond, but with an ongoing oxygen requirement. And I'd say this is where we're really picking up a lot, because as respiratory practitioners, obviously we're we're more confident in oxygen weaning, and so I think certainly we've added a lot by trying to educate other wards which maybe have never had respiratory sort of diseases on them to try and sort of empower them for the oxygen weaning. And we're aiming for target saturations in our trust of more than 90%. Largely that's an oxygen flow issue because we're largely in an older building. We need patients to be on less than 5 litres at rest and no increase in their care need. So just for the sort of ease of the hospital at home pathway, they can't be having to have suddenly, you know, community physio and those sorts of things currently as our model is. And then we've just sort of included within our pathway some advice. I know someone earlier was saying about the dexamethasone. So because we're still classing these people as being in hospital, we're saying that they should continue their dexamethasone and complete the full 10 days. We are also, if they're less mobile, continuing their enoxaparin for a period in addition. And then maybe I'll hand over to Marcello, who's our practitioner at this point, although I haven't seen him on the call. Oh, you are here. Good. And so Marcello, once we've seen someone and been referred them, we see them, we check there's nothing sort of outstanding because they will then be under our care virtually. And then Marcello.
Hi, good afternoon, everyone. My name is Marcello. I'm one of the clinical leads working for Hospital at Home. And just to summarize what we've been created over the last few weeks, when the patient they get referred from the respiratory consultant to our service, an enriched nurse, which is me or one of my other colleagues, we're going to assess the patient directly on the ward, and obviously we assess for suitability of the patient into the community. This type of patient, at the moment, we accept patients with no extra social care needs, so they have to be mobile, pretty independent. And as has been said, we accept patients with oxygen above 90% with maximum 4 or 5 liters. After the patient has been assessed, obviously we assess for suitability, for safety, for oxygen, and we obviously prescribe the oxygen to be delivered on their house. When the patient is discharged, the patient goes home with, we created 2 sorts of different pathways. The most stable one, more independent one, they go home with pulse oximetry, and we advise, as what I heard before, to monitor this one 3 times a day. And another pathway we using monitoring devices is a wearable device that the patient is wearing 24 hours, and it gives us on real time the patient observation, which include respiratory rate, saturation, blood pressure, heart rate, so all the 5 vital signs. So we got trend over 24 hours for those type of patients. The patient that get visited at the first day when they get discharged from one of our nurses, and after the first day, the future visit, they are carried out by telephone calls, or if they wear this wearable device, the consultation is going to be done video call. So there is no anymore a face-to-face visit, but it's just a video call or a telephone call. And during this process, we review observation data, and we wean the patient off over a length of time. At the moment, we notice we discharged the first few patients a few days ago, and the length of stay is around 2 weeks at the moment. And and Sabrine, do you want to go through the numbers you collected for bed days?
So I would say, I mean, other people have said similar, that it does seem in the first wave it was slightly older people. It seems to be that from our first wave, although it was very small numbers we had under hospital at home, they were on oxygen for very prolonged periods of time, whereas the second wave seems to be younger. It seems that we are getting some patients, only needing the pathway for 4, 5, 6, 7 days, something like that. we've got quite an individualized weaning, I would say, where Marcello and his team are sort of ambulating patients. We're doing sort of one virtual ward round a week with a second catch up, where, because it's a 7-day service, where we're identifying patients for the weekend to make sure that we're continuing to see people. But at the moment, I think the last sort of 2 weeks we've seen a really dramatic increase in numbers. So sort of assessing between sort of 6 and 10 patients every day who might be suitable for the pathway. Some patients just don't want to do it, particularly people who've been in intensive care. It's a bit of a leap for them to then go on this pathway, but that's it really. Seems to be working well.
Excellent. Thanks both. So Julia, I think we've got time for a few questions before we wind up.
Right. Well, again, that was really great. Thank you very much. And there's been a little bit of chat around oxygen requirements and the difference between the patient's resting oxygen requirement and their ambulatory oxygen requirement and the length of time. And I guess one important thing is, does it matter? So what are people feeling about that? And should ambulatory oxygen per se just by itself be prescribed? Or should it be just sort of kept at the resting level? And how long are people finding that the patient continues to desaturate on exertion?
Abby, do you want to answer that?
Yeah, Joe and I were speaking about this just this week, actually. I don't know if it does necessarily matter, because we don't check ambulatory sats for perhaps someone who comes in with a pneumonia. I guess the main thing is just looking at the patient. Some patients are significantly symptomatic on minimal mobilization, and I think if you're thinking about how much focus needs to be on their rehabilitation, and without ambulatory oxygen, that's going to prevent some of that perhaps mobilization and recovery process, then I think sometimes a period of ambulatory oxygen can just help that, just like we do ambulatory oxygen for pulmonary rehab or whatever, to improve their rehab. But I agree, we're measuring saturations a lot, and I'm not sure if it matters.
I think that it's for discussion, isn't it? And
I mean, some people, sorry to interrupt, seem to have profound desaturation and are quite symptomatic with it. And then you know, but I agree, it's buttons. And have we got any other questions, Julia?
Well, sort of on the same tack, someone was wondering whether there's ever any reason to do 24-hour monitoring on people, and then are they just assessed in the day?
So some of our patients do have 24-hour monitoring. In fact, one of them, we've ended up in a bit of a pickle because they do nocturnally desaturate, which was probably something absolutely separate. We are doing 24-hour monitoring for some patients, and Marcello identifies which patients he thinks that will be useful for, and I think it is the people who have perhaps had more prolonged intensive care admissions and a higher level of respiratory support requirement.
Yes, is what are we doing? And is, I don't know, it's everything is at the beginning, but having a 24-hour trend give us an idea about the oxygen saturation, increasing or decreasing, and we can see what's happening overnight. And what's been said, we picked up a lot of patients with nocturnal desaturation. So it's a different kind of issue, but it is something that we're monitoring, and we see in the next future.
And there are some questions around the physical monitoring of patients and the sit to stand tests and whether people are using the Your COVID Recovery interactive program app. I'm just wondered if there's any thoughts from the team around those.
Julia, it's Richard here. I'm not sure that that's what that's designed for, and the app's not flexible for that. There are some apps coming along. There's a couple of clinical trials being done, one in London at the moment, so they may well roll out. But an app would be absolutely brilliant to share information, and the sharing's a real worry for me. On the other hand, I would just give you all a big warning. You start using this kind of stuff, you've got to get IG approval for everything, and that takes time and is a pain in the jacksy. So just be aware of that kind of stuff with patient information. So it's coming, but not quite yet.
Yes, and the Your COVID Recovery is causing a huge IG issue around the country. It is trying to be addressed, but it is difficult. Yeah.
Okay, so it's 5 o'clock now, so thanks very much to all our speakers, and thank you all for attending and interacting, and some great comments and questions. So we will go through, and if any questions haven't been answered, we'll answer them if we can. Some things we might not know the answers to at this stage. If there's anything you want to ask by email, there's a generic email address there, and we can direct it appropriately, or you might have protocols or pathways that you're happy to share, and that'd be really useful. It's all about collaborating and sharing. As we said, we'll send the link to the recording of this. And just to mention again, there are some more detailed webinars coming up, focusing primarily at that front end, the COVID oximetry at home and the COVID virtual ward. And I'm sure we'll hear more about oxygen tween at home in the future. So thank you all, and take care.